look at this.
Good afternoon, and today we have a pleasure of interviewing somebody legendary. This is Mariano Rocabado. He joined us from Santiago, Chile. That's why it looks so, colorful on his background. Good afternoon, doctor.
Okay, hello. Very nice to hear you and being able to share with you some information.
Absolutely. And thank you very much to our audience. If you have trouble sleeping or sleep next to snoring partner, this program is going to be for you, because we're going to uncover a little bit deeper. We're going to uncover deeper secret of bad sleep. Sometimes you can't sleep because you have pain all over your body. And we're talking about specifically in your neck, shoulders, hips, sometimes knees. People express to me different reason for pain, what doesn't let them choose any sleeping position or even sleep soundly at night. And if you, medical professional, who just like us, trying to uncover the underlying deep secret of bad sleep, today's program is going to be for you. It's a very unusual topic, and as you know, I bring a lot of body work professionals, physical therapists, to my program to show to my audience what it's not only the narrow look on sleep. This is a whole body, and I'm trying to connect the dots. Now I'm going to tell you about my legendary guest. So I heard about Professor Rocabado for the last maybe 7 years. And it was in a sense how dentists and physical therapists can work together and what we can do together to create long-lasting results. And what patients, after we give them a wonderful smile, can also feel happy or feel content with the results. I'm talking about pain all over the body, because very often people come from orthodontic treatment and they start complaining on the pain in the neck and the shoulders, or they bring complaint on the jaw joint pain, and we don't know what to do, and we just proceed with the beautiful veneers or crowns, and then result can be failure. So Dr. Rocabado, he's a pioneer. It's somebody we all pray to on the topic of organic treatment. So he is a certified manual therapist, and he is a dean of Rehabilitation Science University, Andres Bellos in Santiago de Chile. And he's an author of several books on the head and neck biomechanic and pain and exercise, and I hope he'll share some of the tips on that with us. And he just legendary. He's an honorary member of Argentinian Association of Psychiatry and Kinesiology in Colombia. So he's lecturing all over the world and sharing his wisdom. But we met in person or in the summer on a conference on a AOSH, or American Academy of Physiologic Medicine and Dentistry. And I just attacked him and asked him to do this interview. So thank you very much for doing that, Dr. Rocabado. And I'm going to ask you my first question. I'm going to go right to the ground. I want to know how you can explain that concept of centric relation or craniovertebral centric relation, and that relationship with TMJ function. So basically, how do you find the position what we should use to work with the patient bite?
Well, first of all, thank you very much for allowing me to share some of this information with you. That actually has been my whole life dedicated to this concept of head, neck, and facial pain, with this very special temporomandibular joint that also is the only synovial joint in your body that has teeth. So we cannot think about a position related to the rest of the body in a position of rest without considering the concept of occlusion. It's very interesting to think about this because what keeps us together is actually cranium. It's the position of the cranium. But if you look at the cranium, actually it's divided in an anterior and a posterior relationship. So 50% of the normal function of the head and the neck belongs to the craniomandibular system, basically relating the temporomandibular joint and how the teeth come together in occlusion, but occlusion at rest. The posterior aspect is related to a very important anatomical condition, which is actually the craniovertebral joints, the relationship between the first three cervical vertebrae that are actually constantly in function. The first basic movement, just say yes with your head. That's an occiput atlas joint relationship. Say no with your head. That's an atlas axis relationship. And then say perhaps with your head. That's a C2 on a C3 pattern of movement. So constantly during the day, you're using a three-dimensional pattern of movement. At the same time, you may be saying yes, maybe no, but your head is in constant movement. But it's a 50-50% concept that relates three centric relationships. One posteriorly, craniovertebral. One anteriorly, craniomandibular, and occlusion, in-centric occlusion, but at rest, with disocclusion. So these concepts basically are only trying to find a position of rest, which is the most difficult condition actually to accomplish in clinical practice. In my daily activity, the major reference of patients are because they don't have rest position of the mandible. So if we look at that situation, it's always a functional condition as a 50-50% concept, including occlusion. So it's a tricentric relationship, a craniovertebral posteriorly, a craniomandibular anteriorly, and occlusion at rest. It's a tricentric concept. So we deal with that in an everyday practice. It's a positional fault. If my head is aligned with the rest of the body in a malar sternal position, that's a position where all the muscles around the head and the neck are with the least amount of EMG muscle activity. Once you lose that relationship, immediately the joints go into joint compression by changing what we call functional spaces, spaces that are needed to allow all the neurovascular system that innervates the cranium and the face, basically coming from the upper cervical spine. And this relationship is called the trigeminal cervical nucleus concept. That is, what you have is trigeminal 1, trigeminal 2, trigeminal 3. But at the level of the craniovertebral joints is C1, C2, C3. So you cannot look independently when you're doing a differential diagnosis. If a patient comes in and says, "Doctor, I have a frontal headache." Well, this frontal headache is trigeminal 1. But trigeminal 1 corresponds to the cervical 1 nerve root. Trigeminal 1, cervical 1. Trigeminal 2, cervical 2. Trigeminal 3, C3, cervical spine nerve root. So it's connected not only in a functional way, but also with a neurological link that you cannot isolate. They always are together in a 50-50% concept. If you're doing a diagnosis of the craniomandibular system, you're only doing 50% of the diagnosis. The other 50% is the same cranium aligned with the upper cervical spine. So you always have to think that this is a combined concept of a 50-50%, with a very special relationship with occlusion, but occlusion at rest with disocclusion. It's not a problem of aesthetics or just a nice alignments of the teeth, but all depends in how those teeth also glide between each other and how they protect the system. The teeth are built to protect. So in this concept, you cannot isolate craniovertebral, craniomandibular, and occlusion at rest. It's a tri-centric concept.
This is such a sophisticated concept. But I have a practical question. Tell me, as to the practicing dentist and orthodontist, how manual therapy or physical therapy can create that rest position. Like I saw those wonderful X-ray, what you show during the conference, how, the occlusion totally, off this, three reference points between occiput to C1, C2, C3, and the occlusion plane is totally off. How you put the occlusion plane in a straight position? What's the secret?
The secret is basically it's a very simple concept. When we're talking about cranium and the movements of the cranium in the three planes of space, occiput and atlas, yes joint. Atlas and axis, no joint. C2, 3, perhaps joints.
Mm-hmm.
All right? What you're moving is not the cranium on the upper cervical spine. What is also changing is the positions of the fossa of the temporal bone. So if my head is posteriorly rotated, the fossas are posteriorly rotated. If my head is laterally rotated, you're going to have one fossa up and one fossa down. So
that's what we see a lot. We see a lot.
But if you look at that, which is the name of the joint? It's a temporal mandibular joint, which means that the first thing that you have to align or to know which is the right position or the horizontal position of the temporal bone. Before you can start thinking, where does the disc belong? And then where does the condyle belong on the disc, on the fossa of the temporal bone? So just follow the concept of temporal mandibular joint. The first thing is temporal, then mandibular joint, with the disc or without the disc in position. But to find a normal alignment, not say normal alignment, but a functional, more rested position of the joint, you have to have a normal alignment of the temporal bone. So if you look at my concept, I'm a fossista. I believe on the position of the fossa first, before I can think aligning the mandible on the fossa, with the disc or without the disc in position. So it's just a problem of following the concept. This is a synovial temporomandibular joint. So the first thing we have to learn is about synovial joints physiology, how these joints move, glide, and function without intrajoint compression, without intrajoint tension of the connective tissue, without wear and without tear. And the most important thing, without pain. So we have to think in the joint from the inside of the joint outside, which are the best the joint surfaces are related to maintain a stable position. First thing, the stability of the joints are given only by the shape of the joint surfaces. Connective tissue only holds the joint together, and the muscles only move the joint. But the stability of the joint is only given by the shape of the joint surfaces. This is a dual joint because it has a disc. Disc is synonymous of two independent functions, two independent joints, etc. So you have a condyle inferior disc synovial joint. Then you have a superior disc temporal synovial joint. So you have two synovial joints to take care of.
Yeah.
With differential diagnosis and with different approach to treatment, because they are two independent synovial joints. Usually, we tend to consider only the inferior synovial joint, which is the condyle disc inferior synovial relationship. But who takes care of the disc-temporal relationship? When you have a luxation of the joint, many people says you may have sounds in the joint, you may have limitations of movement, you may have deflections because the disc is not in the right position. But you have to consider that this is a dual synovial joint. You have a condyle disc synovial joint with an independent function and with an independent dysfunction.
How do you put it in the right position? That's what the problem. That's what the question.
No, but the question is you have to understand that the most important thing is the position of the disc in the temporal fossa. So the disc is related to the most deep portion of the dome of the temporal bone.
Yeah.
That's the posterior dense portion of the disc. Then the center of the disc is where the most stable position is for the joint surfaces, where the convexity of the condyle has to meet the concavity of the disc, and the concavity of the disc has to meet the convexity of the temporal component. Then the anterior dense portion of the disc is related to a tangent horizontal line to the inferior border of the eminence. So you have the deep portion of the fossa, and you have the horizontal tangent position of the eminence. In that area, you have to fit the disc. Then you take the vertical from the deep of the fossa, the horizontal tangent to the eminence. You take the bisection of the vertical and the horizontal, and that's where the condyle should fit on the disc and the disc on the eminence for the best stable position of the joint. And that's the position we have to try to accomplish.
How?
Well, you have many ways. One is through images. Today, we're using high-resolution tomography, but it's a three-dimensional condition. We're used to think only on a sagittal position. Probably people says the most superior anterior position of the condyle on the disc. But what happens in the coronal plane? You also have to think that this is a convex on a concave joint surface. So they glide in opposite direction, but they also luxate in opposite direction because it's a convex on a concave joint surface. So they glide in opposite direction and they luxate in opposite direction. So you have to think that what you have is a sagittal observation of the joint, you have a coronal condition of the joint, and if you look at it axial, it's also an axial relationship with the condyle and the disc. So most of the time, people only considers the sagittal observation. But,
this is a very sophisticated topic, but I want to know for my audience, what physical therapist can do, how they, once they find, they know where the disc should belong. They have through the imaging and all of that, but what exactly they do to make sure it's there for the dentist to be able to start working on the occlusion, to support it afterwards?
Well, the basic thing, as we said at the beginning, occiput and atlas, the yes joint. We need functional spaces for the neurovascular system to emerge towards the head and the face. Most of the time, those spaces are decreased. And that's what gives you a headache. This is like having your finger entrapped on the door.
Yeah.
Unless you don't open the door, you cannot take your finger out. So the nerve root, the nerve, the artery, the veins, and all the neurovascular system, they need space. When I move my arm and I make extension and a flexion, the nerve root emerging from the cervical spine has to elongate and then has to retract. That's a movement of the nerve through a space. It has to move. If the space is small, then you have friction or you have compression. That's what creates a neuropathy, which is a mechanical entrapment of a nerve root between two bony structures.
Yeah.
So we need spaces. Most of the time, our patients are posteriorly rotated,
Mm-hmm.
compressing these functional spaces and remain in that position. So they become static, immobile. So the nerve, the artery, and the veins are compressed under a system that doesn't give relief. So the physical therapist has to start inducing distraction to separate the joint surfaces. Then these are synovial joints. They need to glide. They need to glide in anterior rotation. They need to glide in lateral rotation. And they need to glide in axial rotation. So it's a synovial joint concept. You need lubrication. The joints, when they become tight, immobile, they lose lubrication. They squeeze the synovial fluid out. It's like if I put my hands and I do.
Absolutely.
That's what the joint does. Once it becomes squeezed, then it becomes hypomobile. And that's why many times when you release it, you feel it pop. Why? Because you release the suction that happens between joint surfaces when they become compressed. They are sucked in between each other with no lubrication. They don't have the ability to glide. So they need to separate and then start gliding for lubrication.
I have a question what related to releasing. So, I noticed a lot of my patients, they come in a very close position because they grind the teeth. So the space between the teeth becomes smaller. We call it vertical dimension. And as a reflection of its space in the joint becomes smaller. So as a physical therapist, you recommend what we as a dentist to open the vertical dimension to create more space in the joint.
Well, not because you're increasing vertical dimension, you're increasing intra-joint space. The mandible could be only rotating slightly posteriorly, increasing vertical dimension without increasing the distance between the condyle and the deep portion of the fossa. There are two different things. So that's why we usually start doing condyle distraction longitudinal to open up the spaces between the fossa and the condyle and allow basically the disc to be in the right position. So if you look at my hand, this is the fossa of the temporal bone. This is the condyle. If you fit the condyle on the fossa and you have a compressed joint space, the only thing you need to do is to bring the condyle straight down because it's a fossa and all the joint space is open because it's a dome. It's the dome concept of the fossa. I don't need to reposition the condyle anteriorly or posteriorly to set it in the right position. What I need to do is to bring the condyle longitudinal down, and you can see that all the spaces of the joint widens. But you need to bring the condyle down to open up the joint spaces and not reposition the condyles inside the fossa. Always start with long axis distraction. Give space. The disc, you have to understand that the posterior dense portion of the disc has 3 millimeters. The center of the disc is 1 millimeter, and the anterior dense portion of the disc is 2 millimeters. So the 3 millimeters of the dense portion of the disc only needs to open up the space between the posterior wall of the fossa of the eminence with the anterior border of the condyle, 3 millimeters, to allow the dense portion of the disc to luxate. If that space, the space between the condyle and the posterior wall of the eminence, remains 1 millimeter, the 3 millimeters of the dense portion of the disc cannot go through that space. So what's the most important thing? The distance between the posterior aspect of the eminence with the anterior border of the condyle. If it increases 3 or more millimeters, the disc luxates. And because it's a convex on a concave joint surface, they luxate in opposite direction. So if the condyle goes back and increases that space, the disc goes forward. And if that space is more than 3 millimeters, the disc luxates because it's a dynamic joint surface relationship that allows the disc to luxate when you open the anterior joint space more than 3 millimeters. That's what you have to be worried. Not because the condyle decreases the posterior space of the fossa. No, it's the anterior space between the condyle and the eminence that increases more than 3 millimeters that allows the disc to luxate.
Got it. Thank you very much, Dr. Rocabado. And I'm sure, people, medical professionals who are listening to us, they should visit your website and learn about your courses. And I know you visit United States quite often, or people can visit you in Chile and learn from you, because this is a fundamental aspects of the craniomandibular care of the future. Thank you.
This is a very important point, that this is not a single person or a single professional involved on the treatment approach. This is a multidisciplinary concept. You need people that understands your concept of treatment so you can treat the patient the correct way, the most stable position, in a long-lasting position. Don't forget that we have to live at least 100 years. And most of our patients are very young individuals, probably around 28 or 30 years of age is the largest percentage of people having this problem. They still need to live another 70 years, but without pain and without any functional restrictions. So I hope that in one way or another, we have been able to share this information so that we can get interested in how to accomplish rest position of this system.
Thank you very much.
So thank you for allowing me to share this information with you.
Thank you.
So thank you. And